Often when we're consulting with patients about metabolic bariatric surgery, we get asked about whether someone should consider a GLP-1 receptor agonist medication for their problem. These medications are probably more frequently referred to by the shortened term of GLP-1s, and they include the well-known Wegovy, Saxenda and Ozempic, as well as some combination medications such as Mounjaro. I thought it would be helpful to discuss how these medications work, what some of the pros and cons are, and what role they may potentially have in treating lifelong chronic obesity and metabolic disease. You might think that as a bariatric surgeon I'd have a bias against these medications, but I do believe they have a role to play. I do, however, want to try and cut through the hype and exaggeration around these medications in a similar way that you'll see me doing with bariatric surgery. The thing these medications all have in common is that they all contain a synthetic form of glucagon-like peptide, or GLP-1, which is a human hormone that we all produce from cells, mainly in the lower and small intestine. The intestine releases this hormone into the blood when semi-digested food passes by it. Once in the bloodstream, GLP-1 has some critical effects. So firstly, it slows down the rate at which our stomach empties, so food sits in the stomach for longer before moving down the intestine. It also reduces the release of natural glucagon from the pancreas, which reduces glucose production in the liver. This is actually the main essence of the anti-diabetic effect. And finally, it acts in our brain appetite centers to reduce hunger and interest in food. So you don't feel as hungry and it's easier not to eat. All of this leads to some weight loss in most patients. If you've watched our video on how surgery works, you may recall that this sounds very familiar because the medication's main action is to mimic one of the effects of gastric bypass. One of the main mechanisms by which surgery works is by amplifying the release of natural GLP-1 from our gut, which has all these same effects. There are, however, some critical differences in this hormonal effect between gastric bypass and the GLP-1 medications that do bear mention. With bypass surgery, there are several fullness hormones released in addition to GLP-1, including GIP, PYY and others that science probably doesn't know about yet. They're released in a pulsatile fashion in response to meals, with levels going up and then dropping down, a natural cyclical pattern that many hormones in the body follow. And also importantly, they're released into blood vessels that filter through the liver first, called the portal circulation. In contrast, when you have semaglutide, which is the name for Wegovy, when you have these injections once a week, they're given in a large dose under the skin, so they're not pulsatile and they travel into our main circulation that travels around the body before the liver. Now, this doesn't mean that they won't work, because we know there is effect of these medications, but it means that we need to be naturally cautious, because a natural human hormone is being given in a way that it isn't normally. The GLP-1s have been around for over 10 years, but our access to them in this country has been very limited, and they are, of course, very expensive. The hype initially came from a seminal paper called the Step 1 trial, published in the New England Journal of Medicine in 2021. This demonstrated that a weekly injection of 2.4 milligrams of semaglutide given over a year resulted in 15% weight loss compared to 2.4% in a control group. This naturally generated a lot of excitement, as it was a far greater effect than we've seen with any previous weight loss medication. There's been a series of trials following on from this confirming the effectiveness for weight, diabetes and cardiovascular risk. It's important to note that we don't really have any meaningful data extending beyond 2 years yet. What we do know from our patients that have had used these medications, particularly Wegovy, is that they do often describe a switching off of the appetite in that first year, the same switch off that we see with bariatric surgery. For a lot of people who have struggled with excess weight, the sudden lack of hunger can seem miraculous and even liberating. And unhelpfully, but not surprisingly, we've also seen a saturation of hyperbolic claims, often driven by celebrities and social media. So we know they're moderately effective at least up to 2 years in highly supervised trials. They're more effective than generic lifestyle advice and less effective but less risky than gastric bypass. So what then are the downsides that we have to consider for the GLP-1s? Firstly, we know that when patients come off the medications, weight regain is almost universal. Now this is not surprising because, as you've heard me say in the past, after a couple of years, weight regain can occur after bariatric surgery without appropriate lifestyle adjustment. With the medications, it seems to be more rapid because of the sudden withdrawal of all the effect though. So why not just stay on them forever then? Well, if we ignore the very significant cost of that, we need to learn the lessons that we've already learned from bariatric surgery. Your body slowly adapts and adjusts to bariatric surgery, meaning without lifestyle adjustment, it becomes slowly less and less effective over time. Whilst we lack data for the medications, established biological principles tell us that the same thing will happen with the GLP-1 medications. That is, they will become less effective over time. Secondly, we also know that in the real-world use of GLP-1s, unlike controlled trials, it is common for people to stop the medications. Now, this may be for many reasons, but common ones are side effects and costs. A large study published in June 2025 looked at the real-world use of GLP-1s in 51,000 patients and found that 50% of patients had ceased the medication by 1 year and 75% by 2 years. The weight loss at 2 years was only 4.7% compared to 15% in the Step 1 trial. So it seems, as is common in all areas of medicine, the effects seen in clinical trials aren't always able to be duplicated in real life. The third thing of concern is that the relatively high dose of semaglutide in the medication Wegovy seems to cause a lot of muscle loss. In the Step 1 trial, a subgroup analysis showed that 40% of the weight loss was not fat but lean tissue, most of which would be muscle. Now, this is substantially more than the muscle loss seen with bariatric surgery, which data suggests is more like 25%. And the fourth thing that's concerning, and I don't think gets enough attention, is the potential mental health effects of these medications. There is modest data emerging about potential adverse mental health, including increased suicidality. These were significant enough for the TGA in Australia to place a formal warning on semaglutide in December this year, pending further data. To those of us who have been doing bariatric surgery for a long time, this is not surprising. It has been known for many years that bariatric surgery is associated with a slightly increased risk of suicide, so it doesn't surprise me in the slightest that the same effect is seen with the GLP-1s when the mechanism of action is similar. We know that GLP-1, be it from medication or bariatric surgery, acts in the brain to reduce pleasure from food. However, it also seems to reduce pleasure from other things, leading to something called anhedonia, which is a general lack of interest in activities that you once perhaps brought joy. If you take away joy in someone's life without helping them replace it with proper follow-up, then mental health issues can result. Having talked about the problems with the GLP-1s, I want to reassure you that I treat bariatric surgery and its own limitations with the same scrutiny. This should not be about an argument over GLP-1s versus bariatric surgery and which is better. I consider them both useful. They're both very different interventions, each with their own specific role to play in long-term management of lifelong metabolic disease. At which point in your journey medication should be considered is a discussion you should have with your general practitioner. You do, however, need a long-term plan. Just starting the medication to see how you go without thought beyond the short term is a recipe for rapid weight loss followed by rapid weight regain, which is very counterproductive to you in the long term. I want to outline for you some principles that I think should underlie the use of the GLP-1s for weight loss. There is no prospective randomised data in existence for this that I'm aware of, but it's based on my experience in treating patients with obesity with full wraparound care and experience also with the pitfalls of these medications. I also give acknowledgement to the work of Ben Bickman, a cell biologist with an interest in metabolic health, who's produced some very interesting work on GLP-1s. Firstly, semaglutide should be used at the lowest possible dose. The absence of hunger should not be the aim, contrary to the advice of the company, who seem to want everyone to move up to the full 2.4 milligram dose. At lower doses, it may be a useful tool to reduce cravings for carbohydrates, which is a nutrient that we most need to control. Secondly, you should combine the medication with a program of lifestyle adjustment, as I've discussed multiple times in other videos. Most important to this is a dietary pattern that controls and restricts carbohydrate intake, which low-dose semaglutide can help with. To avoid developing tolerance to the medication, you should try to cycle off the medication after a period of time, perhaps 6 months or so, to test if your lifestyle adaptations can allow you to maintain the loss. A further course can be considered in the future. Thirdly, you absolutely must have a program of resistance exercise while on semaglutide to combat the loss of lean body tissue. Not doing this will lead to a problem called sarcopenia, which will lead to far worse problems, particularly if you regain weight. Unfortunately, at the current time, we haven't been able to incorporate the GLP-1 medications into our public bariatric program because they're not funded in this country. However, they are being increasingly discussed, so I hope some of this information, in my opinion, has been helpful.